about all that we've heard in response to a real scenario. This is a scenario we face regularly. Somebody with advanced disease, where the family are saying to us, you must find a way to give them food. Can you put a drip in and give them some food? If he carries on losing weight, how will he ever get strong again? You can't let him starve. Have you heard families saying things like that? Have you? Have you found it difficult to reply? In the light of all that we've been talking about, how are we going to respond to this kind of statement from a family member? So it depends on the cause. So the first thing we're going to do is a very thorough assessment. Absolutely. Do you feel you can assess the problem? So you've been given quite a lot of indicators as how to. It's not a straightforward thing, but like every other problem, a thorough assessment. Thorough history, a thorough examination, and just investigations that are relevant. So let's assess this problem particularly well. And we're assessing it to look at the cause. We're also assessing it to look at the holistic issues that are going on for that patient and the family. And we're also assessing it to see if there are any reversible problems. Yep? So very good. We're going to do an excellent assessment. How else are we going to respond? Very good, Dr. Dungo. So there's a lot of communication issues. What are the expectations of the family? What are the expectations of the patient? Yeah? Are the family really desperate to care for this patient, and the only way they know how is to force more and more food? Can we somehow disconnect food from care, or find other ways to express care other than through food, which I think is what you're saying, Peace? Are there other ways the family can feel as though they are supporting and caring for their relative other than food and nutrition? Dr. Tukikoni, so you're saying we need to be talking about some of the elephant in the room piece, I think you called it. The idea, the knowledge that we all have that this is actually nearing end stage potentially, that actually we feel a little helpless. Do we feel helpless as medical or healthcare workers in this scenario? Yeah. So that actually acknowledging that even to ourselves can help. Do the family feel helpless? Most definitely. Maybe the patient also does as well. So acknowledging some of that and giving room and space to deal with the real issues, which is not actually have they eaten their matoki today, but this person is getting weaker and maybe they're going to die quite soon. Yeah. I had a patient tell me that my relatives are persuading me to eat, and they say if I don't eat, then I'm as good as saying I don't want to be with you anymore. Tricky, isn't it? A very emotionally powerful statement. Okay, any other issues? How we're going to respond? Let's not get into a fight with the families. Yeah, don't be stupid. Sometimes we think that. So let's recognize they're trying to help. Let's try and both come to an understanding that even if we were to give lots and lots of food, for many of the causes that we've discussed today, particularly primary anorexia cachexia syndrome, it's not going to make any difference. So we can even say that even if we were to give 10 times more food than normal, they are still going to lose weight. We might even want to explain that this is a very common symptom and problem. But we want to also try and make sure we don't miss reversible causes. I see many patients with dysphagia due to esophageal obstruction. And early in that disease, it may be entirely appropriate to put in a gastrostomy tube and discuss with our surgical colleagues. I think, Dr. Liz, you mentioned circumstances in chronic neurodegenerative disease or even in acute neurodegenerative disease in which artificial nutrition may be helpful. We were talking about anorexia nervosa earlier. It does have a role there. So we need to be careful we don't rule out all forms of nutrition, but we're trying to divorce nutrition from the emotional impact of this person's going to die and I can stop them dying by force feeding. Okay. Very good. So I think two things I'm hearing you say. One is excellent symptom control. There may be a lot we can do to deal with some of the symptoms, such as nausea, and we should be very good clinicians, very good at prescribing. We shouldn't be giving everybody steroids, but we should be carefully prescribing to manage the symptoms. But the other thing you've said is trying to help people understand that it might be okay. We haven't discussed bowel obstruction, but there are some people in whom we control the nausea, we control the pain, but they still feel hungry. And in those patients, if they want to eat and mechanically vomit every so often, I had a patient who had fish and chips every third day with a complete obstruction, then that might be okay. It takes a lot of discussion, but we see too many people that are nil by mouth. We're actually never going to be able to have a fully functioning GI tract. And so nil by mouth is a little cruel at the end of life. Thank you, Peace. Any other comments? Understanding of anorexia cachexia syndrome? One area we should have just mentioned is some of the roles that physiotherapists and occupational therapists can have. And they are thin on the ground in our setting, but energy conservation, looking at the activities of daily living, looking at what would maintain independence, both in terms of the family functioning and the patient, they can have a very important role. So we should think about that. I worked with a physio that said you have a box full of, like this, of balls of energy, and you have to use them up in the day, so save them for the things that are very important. And think of ways round the daily activities that you normally do, so that you don't waste energy. Respiratory symptoms, for example, the asthenia component of respiratory symptoms is very high. So when we're doing our symptom management, remember the contribution of this problem. Any last comments or questions? It's a problem, and that's why we don't want to get into a fight. Why are the families asking us? Usually because they're worried. So if we can try and say, we're both concerned to do the best for the patient. I can see you're very concerned, you're very worried. You use all your communication skills to try and say, let's together see what would be best for our patient and involve the patient in that discussion. But you're right, we don't always solve all the problems. Sometimes do we treat the families instead of the patients? I see a lot of patients with IV amino acids, IV dextrose to correct hypoglycemia, even IV albumin in these circumstances. So sometimes we do actually, in negotiation with the patient, make decisions such as IV fluids, but be very, very careful you understand the benefits and the burdens of any treatment you start, and be very careful to think of the principle of futility when you make decisions and balance those together. Thank you very much. There's an old Celtic prayer by our national poet in Scotland I'm going to recite for you briefly. The Selkirk Grey. Some hae meat and canna eat, and some would eat that want it. And we hae meat and we can eat, so say the Lord be thankit. Would anyone like to translate? It says some people have food and they can't eat. Some people would like food and they don't have it. But we have both, so let's thank God for it. It's an old prayer from Scotland. Let me just finish actually with something thank you, Dr. Joseph, for reminding us of a very famous physician, Sir Robert Hutchison's prayer, which just helps us think again about some of these benefits and burdens and the ways in which we approach treatment. We looked at it this morning in the mini round, and I asked permission to look at it again from Joseph today. And I think I'm going to read it and ask anybody who would like to join me by reading an old prayer written in the 1950s by Sir Robert Hutchison. It's sometimes known as the physician's prayer. If you want to join me, please do. From inability to let well alone, from much zeal for the new and contempt for what is old, for putting knowledge before wisdom and science before art and cleverness before common sense, from treating patients as cases and from making the cure for the disease more grievous than the endurance of the same. Good Lord, deliver us. Thank you to all our contributors and thank you to all of you.